The following podcast is part of a certified educational activity titled Immune Checkpoint Inhibitor Therapy for Locally Advanced and Early Stage Esophageal GEJ Cancer, the latest evidence and implications for thoracic surgeons and the multidisciplinary care team, featuring Ronan Kelly, MD from Baylor University Medical Center in Dallas, Texas, and Siva Raja, MD from Cleveland Clinic Foundation in Cleveland, Ohio. Access the entire activity and complete the post-test at peerview.com/PSN860. Downloadable slides and practice aids are also available.
Hello, and welcome to this educational activity entitled Immune Checkpoint Inhibitor Therapy for Locally Advanced and Early Stage Esophageal or Gastroesophageal Junction Cancer, the latest evidence and implications for thoracic surgeons and the multidisciplinary care team. My name is Dr. Ronan Kelly. I'm the Chief of Oncology at the Baylor University Medical Center in Dallas, and I'm joined today by my colleague Dr. Siva Raja from Cleveland Clinic in Cleveland, Ohio. Esophageal cancer is the 7th most common cause of cancer-related death worldwide. And in the United States, we see 19,000 new cases expected in 2020 and 2021, and 15,000 deaths expected in 2021. We also know that there's a 2.4-fold higher incidence rate in men than in women. Unfortunately, patient outcomes are historically poor. Often our patients present with advanced disease, and also there's inherent chemotherapy resistance as a result of histologic, molecular, and etiologic heterogeneity. If we just look at the 5-year survival rates divided up into the 3 categories of localized, regional, and distant metastasis, we can see 5-year overall survival rates less than 50%, even in the localized disease, decreasing when lymph nodes are positive to 25%, and then distant metastasis, 5% survival rates, again indicating we need to do significantly better in the next few years. However, we are starting to see outcomes which are improving. Much of the benefits we're seeing are coming from using immunotherapy treatments together with chemotherapies or as monotherapies in the adjuvant setting. As an introduction, everyone has heard of checkpoint inhibitors, but we have numerous drugs now which are targeting the PD-1, PD-L1 pathway, essentially preventing the tumor in some instances from avoiding immune destruction from our T cells. Nivolumab and pembrolizumab are PD-1 inhibitors. There's also PD-L1 inhibitors called avelumab and durvalumab. But these medications and these drugs are really changing the current standard of treatment for patients, and not just in the metastatic setting anymore. In the surgically operable patients, we are now seeing these drugs moving into the first line and in the adjuvant setting. So what is PD-L1 expression? Well, if we just look at the stained slides here, I think it's quite obvious. On the right-hand side, significant staining in brown by pathologists would be determined as a strongly PD-L1 positive tumor or immune cells. And on the left, you can see there's no staining on the immune cells or the tumor. And that's very important because in esophageal cancer, we really cannot just look at the staining at the tumor. We have to look at all the immune cells that are around the tumor. And that's what we mean by the combined positive score. So if you're sitting at multidisciplinary meetings and you're hearing the pathologists and the medical oncologists talk about the combined positive score, or CPS, we're talking about the degree of PD-L1 staining at the tumor membrane, but also on the immune cells that surround the tumor. And the definition of CPS is the number of PD-L1 staining cells, either tumor cells, lymphocytes, or macrophages, divided by the total number of viable tumor cells, all multiplied by 100. And we often determine the score as CPS greater than 1, greater than 5, or greater than 10%. In this case, you can see the majority of patients are CPS greater than 1, meaning they have some degree of PD-L1 expression at the immune cells and the tumor. And 57%, or close to 60% of patients are PD-L1 positive with a CPS score greater than 1. That's important because it's a biomarker to determine whether we will actually use the drug. If we see PD-L1 scores that are less than 1, certainly in the metastatic setting, we've been reluctant to use those drugs. Whether it's important in the adjuvant setting still remains to be determined, and we'll talk about that today as we discuss the phase 3 Checkmate 577 study. So here we are with today's agenda. Even though everyone listening will be surgeons, we did think it's important just to highlight 2 or 3 of the practice-changing trials in advanced metastatic disease, which again are really bringing immune checkpoint inhibitors to the forefront for the treatment of patients with advanced or surgically inoperable disease. And we'll mention 3 trials: Keynote 590, Checkmate 649, and Checkmate 648. These are practice-changing trials. We've been waiting for decades to break through the 1-year overall survival barrier, and we're now doing that with using chemotherapy plus PD-1 inhibitors. All in the last year, we've seen these data presented. The main part of our discussion today, though, is in the surgically operable patients, the patients with stage 2 or stage 3 esophageal or gastroesophageal junction cancers. And myself and my colleague, Dr. Raja, will walk you through the practice-changing results of the Checkmate 577 trial. And finally, we'll have a look to the future, and we'll look at where we see the field moving in the next few years and how important the multidisciplinary care team approach is in the management of these patients. And so we'll now look to see how the algorithm for treating our patients is advancing in metastatic disease. And so the last 12 months has been really practice changing for esophageal and esophageal junction cancer. We've seen really exciting data presented which have changed the paradigm and how we're going to treat these cancer moving forward. We've seen nivolumab with chemotherapy in the first-line metastatic setting being approved from Checkmate 649. And in addition, we've seen pembrolizumab with chemotherapy being approved for esophageal cancer. So Checkmate 649 was predominantly a gastric cancer study with some GE junctions, and pembrolizumab Keynote 590 was essentially an esophageal study with some GE junctions, but both have received FDA approvals, and that's exciting because we've now broken through the 1-year survival barrier, which for years has been an issue which we couldn't get over. So hopefully it's just the start of a whole new era of incremental improvements for those patients. In the second-line setting, we've seen nivolumab is FDA approved for esophageal squamous cell carcinoma, and pembrolizumab is also approved for esophageal squamous carcinoma, but here there is a cutoff. Patients need CPS greater than 10 as per FDA indication. Pembrolizumab is also approved in a tumor agnostic role for patients that have microsatellite instability or mismatch repair deficiency. We've seen across any tumor, if patients have that, they can be treated with pembrolizumab. And most recently, the FDA have given an FDA approval for TMB high tumors. So patients that have greater than 10 mutations per megabase can also be treated in the second-line setting with pembrolizumab if they are TMB high. And finally, third-line indication, pembrolizumab for patients with PDL CPS greater than 1%. And in Japan, we have an nivolumab approval in the third-line setting also. So let's have a look at this practice-changing study that was just presented in 2020 called the Checkmate 649 clinical trial. The design of the study was 2,032 patients who previously untreated but inoperable advanced or metastatic gastric or gastroesophageal junction cancer were randomized. And for today's presentation, I'm just going to focus on the arms in the red box. Patients were either treated with nivolumab, the PD-1 inhibitor, plus chemotherapy, and the chemotherapy here was Xelox or Folfox, or they just got chemotherapy alone. The primary endpoint of the study was overall survival, but also progression-free survival in patients that were determined PD-L1 positive. Secondary endpoints, overall survival progression-free survival, overall response rate in all randomized participants. And here are the top-level results. For the first time ever in metastatic esophageal, gastroesophageal junction cancer, and gastric cancer, we broke through the 12-month, 1-year barrier, with median overall survival in these patients being 14.4 months versus 11.1 months in the chemotherapy alone arm. Hazard ratio of 0.71 with a highly statistical p-value and clear separation of the curves. PD-L1 benefit was more pronounced in those patients greater than 5 as per PD-L1 staining. The second trial I'd like to mention was not in gastric cancer, but was in esophageal or gastroesophageal junction cancer. Quite similar design in that patients were randomized to either get chemotherapy alone, which is the current standard of care, or was the current standard of care, versus pembrolizumab plus chemotherapy. You can see here the entry criteria. Patients had to have locally advanced, unresectable, or metastatic esophageal adenocarcinoma or esophageal squamous cell carcinoma. They had to be treatment naive and have a good performance status. The primary endpoints here were dual in nature. We had overall survival and progression-free survival. Secondary endpoint was overall response rate. The results of the study, you can see here clear separation of the curves with a median overall survival in the intent to treat population 12.4 months versus 9.8 months. And in those that were PD-L1 high, so CPS score greater than 10, which we enriched the patient population here, you can see that the overall survival was even better at 13.9 months versus 8.8 months. Response rates and progression-free survival were also in favor of the chemotherapy plus pembrolizumab arm. And finally, we've now heard a press release in the last few days that in patients with previously untreated esophageal squamous cell carcinoma, the phase 3 trial Checkmate 648 was positive. Again, this trial had a novel arm in that there was no chemotherapy in arm A. You can see nivolumab plus a CTLA-4 inhibitor, which is another immunotherapy checkpoint inhibitor, combined with the PD-1 inhibitor nivolumab. Arm B was nivolumab plus standard chemotherapy. Arm C was chemotherapy alone. The press release has told us that this was a positive study, and we will await further presentation of the data in the near future. I would now like to hand over to my colleague, Dr. Siva Raja, who's an associate professor of surgery at Case Western Reserve University and the surgical director for esophageal diseases at the Cleveland Clinic. Dr. Raja, you're very welcome.
Thank you, Dr. Kelly, for that kind introduction. Wanted to talk to you about why this is important for thoracic surgeons. Trimodality therapy approaches involving neoadjuvant radiotherapy followed by esophagectomy or perioperative chemotherapy before and after surgery are widely used based on the epicenter of the tumor as to whether this is in the esophageal side or the gastric side, as well as based on institutional bias towards adjuvant therapy, whether it's going to be chemoradiotherapy or with chemotherapy. In the United States, chemoradiotherapy followed by surgery is the preferred treatment based on a CROSS trial that was reported almost 10 years ago at this point. However, if we are using perioperative chemotherapy, then FLOT has been the preferred regimen until 2020. There is increasing data to show that immunotherapy has a role in esophageal cancer, not only in the palliative setting, but recently also in the adjuvant setting for locally advanced disease, stage 2B or stage 3. So I thought that we would talk about this in the setting of case presentations. So the first case I want to talk to you all about is a 70-year-old man with a 2.5 centimeter mid to distal esophageal nodule, which presented with dysphagia. His clinical staging is clinical T3, N0, M0, and M0, or G2, which is moderately differentiated cancer. He has a relatively benign past medical history, except he has Barrett's esophagus, has a hiatal hernia, atrial fibrillation, and has had a previous hiatal hernia repair. This is a representative slice from a PET scan, which shows a mid to distal esophageal tumor with an SU of 11.9. On endoscopic ultrasound, in the endoscopic ultrasound, he has a T3N0MX clinical staging. At this point, I want to talk about the potential options for this patient. The decision tree from our standpoint is chemotherapy versus chemoradiotherapy, and using a multidisciplinary consult to identify the best therapeutic regimen in this setting. Given that he at this point qualifies for trimodality therapy or induction therapy, the decision from a surgical standpoint, whether you get chemotherapy or chemoradiotherapy, often has to do with the epicenter is in the gastric side or the esophageal side. So in the esophageal side, oftentimes we would prefer chemoradiotherapy. But I want to ask Dr. Kelly what he would offer in this situation. Dr. Kelly?
Yeah, and I would agree, in my practice, we prefer chemoradiation in these distal esophageal and GE junction tumors. Maybe later we might talk about CWORT 3, but certainly for distal esophageal, CWORT 1 or 2, my preferred option has been chemoradiation.
So in the multidisciplinary consult, we not only look to see what the best treatment is for that stage of cancer, but this is exactly the time to identify whether the patient will indeed tolerate the therapy that we have to offer, such as chemoradiotherapy followed by surgery or chemotherapy followed by surgery followed by more chemotherapy. So identifying what patients are able to likely undergo surgery at this point allows them to differentiate their therapy as to either getting trimodality therapy or definitive medical therapy. So this patient ended up getting induction cross chemoradiotherapy, and they underwent a right-sided video-assisted thoracic surgery approach assisted McEwen esophagectomy. His post-induction pathologic stage was T2N1M0G3 or poorly differentiated adenocarcinoma. He had 1 out of 36 lymph nodes positive. The resection was R0 resection where the proximal, distal, and radial margins were all negative. His PD-L1 had a combined positive score of 5. His microsatellite was stable, and his HER2 new marker was negative. So in the setting of this patient, where he still has a fully resected cancer, but he still has histologic and pathologic features that are suggestive of high recurrence possibility, we always try to identify patients who are otherwise healthy, and we are often asked the question, is there anything else to offer? And the answer usually is that there isn't enough data to support whether additional therapy would be beneficial, possibly until now. However, when patients are treated in a wide variety of settings, often the local oncologist might decide to give additional therapy. While we all agree intuitively that it makes sense, until recently there hasn't been any data. Dr. Kelly, what are your thoughts on this?
This is a great question, and this was really the gaping hole in the management of esophageal cancer. I can't tell you how many times over the years my surgical colleagues have called me saying, Dr. Kelly, unfortunately, this patient has not had a pathologic complete response. Some of the lymph nodes are positive. Can you do anything else? Because we know that they're going to, recur in all likelihood. And that's been a challenge, because then you tell the surgeon, well, unfortunately, we don't have any data on chemotherapy. Once you've had trimodality therapy with chemoradiation and surgery, there hasn't really been any great prospective data on the benefits of chemotherapy. And I think many surgeons are surprised by that, because they just presume we can give more chemo. But that has not been the case. And that was really the reason, Dr. Raja, why we actually designed this study, which we're going to talk about, was exactly for this type of patient. And remember, this makes up approximately 70 to 75% of all of our patients, because only about 20 to 25% indeed have a pathologic complete response. So the majority don't, but we haven't had any data. So that's why we did the Checkmate 577 study, which I'll come on to now. So if we just move to the next slide. So one of the problems we've had is, what do we do for these patients? Because unfortunately, they're typically very frail after surgery. They have, to relearn how to eat, how to get calories in. More chemotherapy has been very arduous for these patients, and we haven't had any data to show that it's beneficial. So a number of years ago, I worked with some colleagues to design a study whereby we could utilize the PD-1 inhibitor nivolumab in the adjuvant setting post-trimodality therapy. We didn't really have much data, but we knew that radiation, in fact, caused PD-L1 expression to change. You can see here just some animal data that we did a few years ago, and we published it in 2018. You can see PD-L1 expression in an animal model post-radiation goes up. Now, it does tend to trend down, but the idea here is when you give radiation, you cause interferon gamma release. You actually can drive up PD-L1 expression and other immune checkpoint inhibitors, and we think we make the immune system more hospitable to give a checkpoint inhibitor. And that's some of the background for the Checkmate 577 study, which we're starting at the end almost here, but just to tell the audience, this was just published on April the 1st, 2021 in the New England Journal of Medicine. You can see here the number of locations throughout the world. Most of our data in operable esophageal and gastric cancer, in fact, has come from single country studies like the United Kingdom or Germany or Holland or Japan. We haven't had multiple countries participating in a large randomized double-blind phase 3, which was the design of this. And you can see this was done in 167 study locations across the globe. The design of the study, if we look at it, was any patient could have stage 2 or 3 esophageal or gastroesophageal junction cancer. They could either have adenocarcinoma or squamous histology. Every patient had to have neoadjuvant chemoradiation and surgery. We did not define what type of surgery they should have or which chemotherapy they should have, or in fact, what dose of radiation they have. They were all given treatment according to their local doctors and their local surgeons. But what we said was every patient had to have standard of care chemoradiation. And then when the pathologist reviewed the surgical pathology report, they could not have a pathologic complete response. So we excluded those 20 to 25% of patients with the best biology disease. So now we're left with those 70 to 75% of patients who were in desperate need of some new treatment options. So that was the design of the study. Patients who didn't have a PAT-CR were then able to be randomized on the study. And you can see here we enrolled 794 patients. 532 patients got nivolumab. 262 got placebo, which again is the current standard of care because close observation is the current standard. So nivolumab was given at 240 milligrams every 2 weeks for the first 4 months. And after that, then we increased the dose to 480 milligrams on a monthly basis. So the first 4 months was more intense for the patients. They had to come every 2 weeks to get the PD-1 inhibitor. But after that, for the next 8 months to round out the year, they came once a month. And we presented data at ESMO and in the New England after a median follow-up of 24.4 months. If we just look at the baseline characteristics of the study, you can see the median age were well balanced. If you just look down at the tumor location, 60% were esophageal cancers, 40% gastroesophageal junction cancer. The majority of patients had adenocarcinoma, which is not unexpected, of course, in the United States or in Europe. Certainly in Asia, there's more squamous cell carcinomas. If you just look at the number of patients that had pathologic lymph node status, again, this was post-surgery YPN1 positive disease, 57% in the nivolumab group, 58% in the placebo group. So really quite well balanced across both groups. Now let's look at the top-line data. So here we see the primary endpoint of the Checkmate 577 study, which was disease-free survival. The treatment arm with nivolumab doubled the median disease-free survival from 11 months for those patients treated with placebo to 22.4 months for those that received nivolumab. Hazard ratio 0.69 with a highly statistical p-value. The Kaplan-Meier curves, you see early separation, which is sustained across the duration of the treatment in patients that receive nivolumab versus placebo. I think actually the placebo arm here really highlights to us the challenges in close observation for these patients. You can see they have a median disease-free survival of 11 months. We haven't had this data in a prospective randomized double-blind study before, which is truly global. And I think it shows that really we can't just watch these patients anymore. Post-trimodality therapy, if they have residual disease, YPT1, YPN1, in my opinion, they should now be treated with adjuvant nivolumab. And this is the reason for the FDA approval and the listing on the NCCN guidelines, because we've doubled the median disease-free survival and we've decreased the risk of recurrence or death by 31% in these patients. Highly statistically significant result and really a practice-changing result, which I think is we've been waiting for a long time. As we await the overall survival data, we do have another endpoint, which is not overall survival data, but it is an interim step after disease-free survival. This is called distant metastasis-free survival. So how long are you preventing the recurrence or the occurrence of metastasis? And you can see here in those patients that got the nivolumab arm, the median metastasis-free survival was significantly longer, 28.3 months versus 17.6 months. Hazard ratio here, 0.74. People may ask, well, what was the outcome according to histology? Because actually we know that squamous cell carcinomas tend to be more sensitive to the immunotherapy drugs than the adenocarcinoma group. But here you can see, we did see that, but we also saw really quite significant benefits in adenocarcinoma. With the median disease-free survival in the adenocarcinoma group, 19.4 months versus 11.1 months, hazard ratio 0.75. And then if you just look at squamous cell carcinoma alone, you can see here we did expect to see this, but obviously a much better improvement. Median disease-free survival versus placebo, 29.7 months versus 11 months. Hazard ratio here, 0.61. So I think, people look at this data and they can see there's a clear benefit from giving adjuvant therapy in those patients who have not done as well as we would have hoped with trimodality therapy. If we look at the results according to disease-free survival by subgroups, you can see the DFS favored nivolumab across multiple pre-specified subgroups from adenocarcinoma to squamous cell carcinoma to the lymph node status, tumor cell PD-L1 expression did not seem to have a huge benefit here. There is some slight difference between esophageal cancer and gastroesophageal junction cancer, but if you look at the placebo arms, there was quite a difference in terms of esophageal versus GE junction. If you look at the treatment arm for esophageal cancer, 24 months, and in GE junction, 22.4 months. So again, we saw disease-free survival favoring the treatment arm across multiple pre-specified subgroups. This is just some additional data. Again, for our surgical colleagues, this will be very interesting. The third category down, how well did patients do according to how long they were after their esophagectomy? You could see here that we just broke it down into 2 time points, at less than 10 weeks after esophagectomy to start on nivolumab versus greater than 10 weeks. And you can see here that there was a big difference in the hazard ratios of 0.84, 0.66. So we think patients should really start on this once they've recovered adequately from their surgery. And it's such a large operation. It's going to take patients a couple of weeks to recover. So we don't think you should start patients on this immediately. In my opinion, after 10 weeks is a good time point. And we even had the study, it went up to 16 weeks after surgery. So there is a nice window there where patients can start on this nivolumab once they've recovered from their esophagectomy. So here we see the NCCN guidelines for esophageal and gastroesophageal junction cancer. In fact, the NCCN committee introduced nivolumab as Category 1 evidence back in December of 2020. And you can see here that they did that for both squamous cell carcinoma and adenocarcinoma in the R0 resection group. Any patients with squamous cell who have YPT positive or N positive, nivolumab listed as Category 1 evidence and is now FDA approved. And similarly in adenocarcinoma, any patients that are receiving preoperative chemoradiation who have an R0 resection, but again, YPT positive or YPN positive, can now be treated with nivolumab as per the NCCN guidelines, and this has also received FDA approval. What about safety? Well, the take home here was we know, medical oncologists know all the adverse events because we've been giving these drugs for so often in the more advanced metastatic setting. This is one of the first studies actually which has given these checkpoint inhibitors as adjuvant setting in any tumor type. The only data we've had prior to this study was in adjuvant melanoma, where it's common practice now to use a PD-1 inhibitor. It's very unusual that esophageal or gastroesophageal junction cancer is then leading the field as the second tumor along, which has shown a benefit from adjuvant PD-1 inhibitors. And that was the case here, but we've shown obviously the benefit in terms of the efficacy analysis. But thankfully, if you're going to give an adjuvant treatment, you want to make sure your patients can tolerate this quite well and they don't have a decrease in their quality of life or their performance status. What I would say is with regards to the adverse events, nivolumab was very well tolerated. The majority of treatment-related adverse events were grade 1 or grade 2, and there was no safety signals that jumped out at us. What about those with potential immunologic etiology? Well, we were looking, we have a whole host of potential immune-related adverse events, which you will all know about in terms of pneumonitis or dermatitis or colitis or thyroid dysfunction. In fact, any itis is possible. But we did not see that much in terms of toxicity. The majority of selected treatment-related adverse events, again, were grade 1 or grade 2. In those that were grade 3 or 4 occurred in less than 1% of patients in the nivolumab arm. If you actually picked out, though I was slightly worried about pneumonitis when we were designing this study, but we only saw that at 0.8% of patients, and that occurred in the placebo arm at 0.4%. So really no big increase in the adverse events, and that was very reassuring. As I mentioned, all of your medical oncology colleagues are very well versed now in the management of any immune-related adverse events. The most common ones are listed on the left-hand side. Skin rash obviously is quite common, as are the endocrine abnormalities where the immune cells can affect the thyroid, but we can give thyroid replacement there. The GI ones, we did not see many GI side effects on this study like diarrhea or colitis. So overall, the treatment was well tolerated. Now, what about quality of life and the overall health status of patients for the year? That was really important in an adjuvant setting. As I mentioned, you need to be able to show that patients that if they go on this treatment, they're going to tolerate it quite well. And this was really an important slide for me in this adjuvant study. You can almost see here that the lines are superimposable. These are some quality of life healthcare questionnaires where every time the patient was coming in for the treatment, they were asked a series of questions about how their quality of life was. And you can see here nivolumab versus placebo from week 5 onto week 53, really quite similar in the visual analog scale, or another patient questionnaire called the utility index, where patients were reporting very similar outcomes, very similar overall health status between those that were on the adjuvant PD-1 inhibitor nivolumab or those that were getting placebo. This was very reassuring and I think is very helpful for our surgeons and our medical oncologists to know about. So that's really the last slide on Checkmate 577. What we thought we would do now is just start having a conversation about where do we see the future of immunotherapy. I've already mentioned, to summarize, We've seen a number of practice-changing trials in the metastatic setting, just in 2020 and 2021. And now we've seen a practice-changing study in the adjuvant setting. So where is all this moving? I think it's very exciting for our patients, very exciting for us as doctors and surgeons that have been treating these patients for many years. We're now finally beginning to see some big benefits emerging as a result of turning on patients' immune system. So I think Dr. Raja may walk us through another case. Dr. Raja, please.
Well, thank you, Dr. Kelly, for that update, as well as the excellent work by you and your colleagues on 577. So I'd like to, before we talk about another case, another clinical scenario where we'd like to hear your opinion on how this might, the immunotherapy might impact it. I just want to take a moment to acknowledge the gravity of this trial. For a long time, we have been dealing with the idea that we've given people a pretty aggressive therapy, and yet afterwards, looking at the pathology, we know that a good number of people are going to recur. And the guidelines have always been watchful waiting. And the idea of watchful waiting for something that is going to happen has never really sat well with a lot of people. So I think finally, I believe that we have another option that is backed with data that's going to be helpful for our patients. So I think that we're looking forward to the era of immunotherapy where we can impact the care of our patients, both in the perioperative setting, but as well as long term. Historically, the idea of giving more conventional therapy has never really sat well with all the oncologists and even some surgeons, is because just because they have bad disease doesn't mean they need bad therapy that's not backed by any data. So I think the immunotherapy is something that's very promising. I'd like to take a moment to talk about another case scenario. This is a 65-year-old man that saw me with a 3-month history of worsening dysphagia and anemia. He underwent clinical staging, which suggested it was T3N1M0G3, or poorly differentiated GE junction adenocarcinoma, and had actually a significant amount of cardia involvement. So this is the PET scan itself, and we can see that the GE junction, as well as a good amount of the cardia, is actually involved. His past medical history is otherwise unremarkable for other than hypertension, BPH, and he had an appendectomy at an earlier age. So when looking at the PET scan, we see that it's pretty PET avid, as an SUV of 12.4. There's no evidence of distant metastases. The issue from a surgical standpoint over here is that we often shy away from giving cross in this patient, because once you've radiated the field and then you go to the operating room and then find that you have margins positive on the gastric side, then all of a sudden you start limiting the gastric conduit that's available for your reconstruction. And while it's possible to do reconstruction in a radiated field, we try to avoid it as much as possible. Anastomotic leaks are highly morbid, and especially anastomotic leaks that can affect how the person does long term to be able to get through the therapy and then get to additional treatments. So I think that this patient, we will always be shying away from cross. And so he actually ended up getting adjuvant FLOT and then underwent a robotic Ivor Lewis esophagectomy. And in the post-operative period, we noticed that his post-induction stage was YP T3N3M0G3. So it's stage 4A disease based on the extent of lymph node involvement. So this patient had 10 out of 52 lymph nodes positive. It was a grade 3 response, which means that they pretty much had no response to the FLOT. And the patient did have an R0 resection, but with the number of lymph nodes that's involved, even with the number of lymph nodes that was resected, the concern is that there's other disease elsewhere, especially given the disease burden. His PD-L1 was positive at a high CPS score, and the MMR was proficient, and his HER2/neu was negative. So in this setting, I would like to ask you, knowing how poorly this patient is likely to do because of the burden of residual disease that he had, even with an R0 resection, what do you think the role of immunotherapy would be here?
Well, so we do not have data yet on this case. So as I mentioned, Checkmate 577 is data when they've got chemoradiation. So we do not have the data yet on if they've just gotten perioperative chemotherapy. However, those trials are done and are completed, and we should get results soon. So if we look at some of the studies that have completed, Keynote 585 is a study involving pembrolizumab. And so here what they've looked at is patients with resectable disease either getting chemotherapy alone, and there's two different types of chemotherapy you can see there. It's either the FLOT chemotherapy, which is just a triplet, versus 5-FU platinum, which is obviously a doublet, plus or minus pembrolizumab. So this question will be answered, Dr. Raja, I would think pretty soon. The query in my mind is, and most of the audience that are watching us today, I know, are also surgical, are lung cancer surgeons. These tumors are not as sensitive to the PD-1 inhibitors as we see in lung cancer, because we've seen tremendous breakthroughs in lung cancer over the last 5-10 years. As you're saying, we're just starting to see the advances now in esophageal and GE junction cancer. So the question in my mind, though, is does the tumor need to be out like it was in Checkmate 577? Are we just dealing with minimal disease burden? Or will you still see efficacy when the tumor remains in, which is what a perioperative strategy is, because you give 4 cycles before surgery and then 4 afterwards. So we'll just have to wait and see. Let's hope that this is a positive trial. I believe it's fully enrolled. We will see how that the results of that in the near future. And then there's a number of other studies there. You can see some of the cooperative groups in the United States have a phase 3 trial looking at nivolumab plus chemoradiation in the neoadjuvant setting, which you remember we did not do in Checkmate 577. So we gave everything in the adjuvant setting, but this cooperative ECOG study is giving chemorads plus nivolumab even before surgery, and then adjuvant PD-1 inhibitors once they've recovered. So there's different strategies at play here. And then there's also another study called the Dante study, which is also looking at another drug called atezolizumab, which is a PD-L1 inhibitor. Is it better to combine with FLOT versus FLOT alone? So these are 3 studies which I think we'll start seeing the results of probably in the next couple of months, or certainly in the next year, which will also help us as we try to define the optimal strategies.
You know, it's exciting to hear that there's more coming along this along these lines, especially in this patient population that has not had a great prognosis and probably still don't have great prognosis as of today. So hopefully this will change that for the future. The other thing I would say is that from the standpoint of from surgeons, I think that the idea of treating disease with the index drug and then seeing if it had a benefit. So as the case example we were just talking about, the patient underwent FLOT and they had a grade 3 response. So if you're thinking about patients who have adjuvant therapy and maybe even neoadjuvant therapy and then adjuvant therapy afterwards, I think that the knowing whether it's actually impacting the tumor is a lot more palatable to the rest of us. We'll have to see what the data shows, obviously.
Dr. Raja, can I make a quick point here?
Please.
I wanted to make just sure everyone appreciates how vital the input of the surgeon is in these studies, because I can tell you in Checkmate 577, it was relatively slow enrollment, as people aren't rushing to go on an adjuvant study. But what we saw was when the surgeon encouraged their patients to go on the trial, enrollment went up 2 to 1. So it just shows you how powerful the voice of the surgeon is in these neoadjuvant or adjuvant studies, even though it may be the medical oncologist who's giving it, but it's a true multidisciplinary team approach. But the surgeon's voice is so powerful for those patients. And I was grateful for all the surgeons that participated in the Global 577 study, because they really helped make it possible.
No, thank you for saying that. I think that the days where, surgeons were purely technicians, where, you drop them off, they get their procedure, and then they get dropped back off at the oncologist's office, I think that paradigm is no longer accurate. I think that we are, heavily involved in the decision-making process in the perioperative period. That's where the multidisciplinary evaluation comes in. And even in the post-operative multidisciplinary evaluation, where in the tumor board, where the pathology is reviewed, as well as the conduct of the case is reviewed, and then a combined plan is made as to how the patient did, how the patient's doing, how well they are. All of these things go into account before even starting the conversation about what to do next. So I think that there's going to be constant flow of information, bidirectional flow of information between the surgeons and the oncologists. And I think that that's the new paradigm, and I think that's a great paradigm.
Yeah, it's a whole new era, right? It's a whole new era. The fourth pillar of cancer treatment has arrived in operable settings. So, it's exciting, and the surgeon needs to be aware of this data moving forward, because it's going to directly impact their patients and how they're going to do in the long term. So I think it's tremendously exciting, I hope, for the surgeons,
And I think, understanding the data is important, in that, especially when they're talking about surgery, and it's a very invasive surgery, no matter how you do it. And the patients, form a bond. They ask your opinion. Sometimes they ask your opinion on things that you're not as proficient about. And I think that was where, especially in the setting of, should I do something in the adjuvant setting? My oncologist wants to give me more chemotherapy. What do you think? Well, a lot of times, we want to say, yes, go ahead and get chemotherapy if you can. But at the same time, we also know that there's no data behind it. So I think understanding what's out there, understanding what the role of each therapeutic modality is, allows us to also be another voice of advocating for our patients. I think that everyone's looking out for the patient, and I think being on the same page actually makes the patient more comfortable that they are doing the right thing. And also that tells them that if there is a complication, that we're all there to help them get through it. So I think that providing that level of support and confidence, I think, is going to only come from every member of the team, oncologists, radiation oncologists, and surgeons, all being on the same page about what the therapeutic regimens are. I think NCCN made guidelines are a godsend in terms of getting everyone on the same page. But we still have a lot of institutional protocols, and there's also people who, there have variations of things. And I think this understanding the trial data and what the trial actually said, as opposed to the extrapolations off of that, are going to be important. So not only is it important to understand the data, but having this conversation periodically with your oncologist so that you're both on the same page is going to be crucial in going forward and taking care of these patients.
So before we conclude, let's take a look at some of the audience questions that are coming in. So one of the first questions is really about, why did we pick this patient population to do the first, study in? Well, I think that's a great question. It's obviously got multiple answers, but what I tried to explain was this was a big gaping hole in the therapeutic landscape for esophageal and gastroesophageal junction cancers. We've obviously seen some benefits in the last 5, 10, 15 years in terms of tinkering with the chemotherapy, changing the radiation dose. There's been surgical advances, but we haven't had any improvements in the adjuvant setting because there's been no data on what to do. So that's really a huge problem, of course, because the vast majority of our patients, 70, 75%, fall into that category. So we're not talking about a small population of patients. We're talking about the vast majority. And we needed data. We needed a global study to show us really definitively how poorly people did with close observation. I think we've seen that now with an 11 months disease-free survival. It's quite harrowing to look at that in terms of in patients that we think we're treating with best care, and they're still having a disease-free survival of only 11 months. So that was really the reason why we did it. I think it was to help answer a question about using a novel therapy in the adjuvant setting, which is well tolerated. And I think Checkmate 577 ticks a lot of those boxes. I certainly hope it's not the end of our advances. I hope it's just the start of a whole new era. But I think doubling the disease-free survival from 11 to 22.4 months is a very big step forward for one particular trial. And let's hope we see more incremental and bigger benefits coming in the next couple of years. So we got some other questions about, was the dose of radiation, was that important? So we have that data in the supplementary appendix of the New England paper. So if people want to look at that, we did not see the dose of radiation making a significant impact. Again, we did not define up front. People may say, why did you not define the treatments of what chemo, what radiation, what surgery? Well, again, when you're doing a global study, it's very hard to build in all of that across multiple continents, because we all know our Asian colleagues do slightly different things than what we do. The surgery can be slightly different. And so we left that as standard of care, but then we said anybody who has not had a pathologic complete response. So it was almost like we were letting the biology of the patient's tumor, dictate if they should come on the study or not. And that's why we did it that way. But we did not see the dose of radiation affecting disease-free survival. Dr. Raja, any comments? We didn't really see any impact on what type of surgery they got. Is that surprising or not?
No, I think that the operation is often based on two things. One is location, and like for example, if you had a mid-esophageal cancer, odds are most likely people would get a McEwen esophagectomy, especially if you're talking about an induction chemoradiation setting, because you want to get outside the radiation field. And I think that from a GE junction standpoint, the vast majority, at least in the United States, would do an Ivor Lewis. I think a lot of decisions between Ivor Lewis versus McEwen actually has to do with surgeon preference, your training pathway, where did you train, what did you train with, and all of those things. There's a whole host of things that make a difference. So there's one element that says the biology determines, or the location determines what operation, but I think far more commonly, it's the surgeon preference. It is what we call a high complexity, low volume operation, at least in the United States. And so you want to do that operation the way you know how to do it best, the way you were trained, which you're comfortable with, and that's how you're going to get the best results. So I think for that reason, I am not surprised that surgeon preference of procedure did not impact how it happened, for the most part. Yeah. Let me ask you a follow-up question, if you don't mind. I think that at the end of the day, at least for now, the question always comes up, now that this information is out there, so how does one access this drug for use today?
Yeah, well, because it's listed on the NCCN compendium when it was listed in December with Category 1 evidence, that means that doctors throughout the United States can prescribe it. They have, it's covered by the insurance carriers. So anyone is able to access that now based on the fact that it's got Category 1 evidence in the NCCN.
And that's for the adjuvant setting in patients who are not metastatic.
Correct. So, to use some of your examples, if someone was treated with FLOT alone, and as you showed in your example, a number of lymph nodes were positive, that will not be the indication because we haven't done that study. We've only done the study with chemoradiation as the induction treatment. So that question comes up a lot, but we have to wait and see those data. We don't have that data yet. Just the trimodality treatments, chemorads followed by surgery. If you don't have a path complete response, then you can get access to this drug.
So, did you notice in your study that if the CPS score preoperatively versus postoperatively, was there any change? Was there any sampling error related issues, or just the fact that they got treated, did it change the CPS score?
It's a great question. Of course, the very nature of adjuvant studies is they take much longer to do than metastatic studies, right? So it takes us a long time to get the answer. But when we were designing this study a number of years ago, actually, we were looking at PD-L1 expression on the tumor alone, not on the immune cells. Even though I mentioned the immune cells is important, that information has already come to light in the last couple of years. But when we're designing the study, we used tumor cell PD-L1 expression. We did not see a difference in outcome according to tumor PD-L1 expression. When we were writing the manuscript for the New England Journal of Medicine, our reviewers did ask us to do a post-hoc analysis on CPS score, and we did see the CPS score impacting the efficacy. However, it wasn't a planned analysis. It was a post-hoc analysis and all of the issues that come with that. Also, as I mentioned, radiation can change the immune microenvironment because you're radiating the lower part of the esophagus. You're causing cellular damage you're causing interferon gamma release. That causes upregulation of PD-L1. So we don't know if PD-L1 post-radiation is the same as, a baseline endoscopic biopsy where you haven't done anything with the patient yet. Because PD-L1 is a dynamic biomarker, our treatments can cause it to go up. So a lot of work still needs to happen in that space. The other question people are asking me, which is really important, I think, to bring to light, is the role of circulating tumor DNA. We're hearing this now in every tumor type after surgery. Obviously, colorectal cancer has been really leading the field in this, but we know that those patients that have circulating tumor DNA levels post-surgery are doing quite poorly. We do not have that data yet in this study, but I hope that'll be something that can be done. But I think that's going to be just as important as the TNM staging moving forward. What is a patient's ctDNA? Because in many ways, it indicates whether they've got micrometastatic disease. If the surgeon takes out everything that he or she can see, but the patient still has circulating tumor DNA, in my mind, there's some residual disease. It's just not visible with the naked eye, or it's not being detected on our imaging. But we've always known our imaging is not very good, in terms of we can't identify cells when they're in the thousands or the millions. We need them to be a billion to make it 1 centimeter on a scan. So I think ctDNA is going to be an emerging biomarker that we'll all be using in the next couple of years.
So along those lines, let me ask you this question, which is, the incidence of brain metastases in esophageal cancer is actually quite rare in the presentation setting, but we do see a higher incidence of brain metastases in in patients who've undergone trimodality therapy, but in long-term follow-up. Does immunotherapy go through the blood-brain barrier? Is it effective for brain metastases or not?
Yeah, immunotherapy, because again, the immune cells are smaller than the blood-brain barrier, the holes in the blood-brain barrier. So the immune cells can get through. But we're really looking at that now. We've seen data emerging in tumor types that the checkpoint inhibitors work very well in, like lung cancer, melanoma, head and neck cancer. We have seen data that brain mets can improve. We don't have any data on that yet in esophageal or gastroesophageal junction cancer, but I think we will be looking at that in the future for sure. I think we're maybe out of time. We may have time for one more question. People are asking about the outcome after surgery. What's the optimal timing? I think I mentioned that. I think the 10-week cutoff is pretty good. It just means I don't think the surgeon has to be telling the patients you have to start straight away. Let's get them to recover from their esophagectomy. Let's let them work with the dietitian and the rehab folks to get their strength and their energy and their calorific intake back, and then we can start them on the treatment. I think that's going to be the optimal way to do it.
So in conclusion, I think that the take-home message is that the multidisciplinary planning, preoperative and postoperative, are going to be very important in the care of patients with esophageal and gastroesophageal junction cancers. I think input from the surgical side, whether it's from surgical oncology or from thoracic surgery, or and the medical oncology, radiation oncology, as well as gastroenterology, who are instrumental in both the diagnosis as well as in staging with endoscopic ultrasound, as well as in follow-up, are going to be important. But also involving oncologic nurses and pathology and palliative care are all part of the multidisciplinary planning. And I think that going forward, each member is going to be a valuable member contributing to the team.
Thank you very much indeed, Dr. Raja. Thank you very much for joining us.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/PSN860. This activity is supported through an educational grant from Bristol Myers Squibb. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.